Let's go ahead and get let's go ahead and get started. We've got a lot to get through today, and we want to make sure we leave plenty of time for our fabulous speakers. Thank you for joining us today for our September webinar, and happy NICU Awareness Month. For those of you who are joining for the first time, I'd like to extend a warm welcome and remind everyone that a recording of this webinar and all slides will be published on our website, fcctaskforce.org, as well as shared in a follow-up email, which we encourage you to share widely with your colleagues. Today's webinar honors Elizabeth Simonton's son, Benedict, who was born term with complications related to Beth's diagnosis of polyhydramnios in her second trimester. Benedict was in the NICU for only a short time, but regardless of whether a NICU stay is 1 day or 100 days, we know that it changes you forever. Compiling photos for our dedication slides always makes me emotional, and I want to acknowledge the feelings and traumatic memories that resurface as these are sifted through and sent to us. Thank you, Beth, for using your family's struggles to benefit us all and for these beautiful pictures of Benedict's NICU journey. This work wouldn't be possible without our esteemed organizational partnerships. It's incredible to see so many parent-led organizations alongside prestigious medical associations, and the amalgamation of these partnerships is part of what makes the FCC Task Force so special. A warm welcome to PPROM Foundation and to Kimberly Novad Saul's Light. I'd also like to acknowledge Reckitt Mead Johnson, whose mission is protect, heal, and nurture in pursuit of a healthier world. Reckitt Mead Johnson is one of our industry sponsors for today's presentation. And I'd like to acknowledge our second sponsor for today's presentation, Draeger, Care for Babies Like Never Before. As a reminder, we follow the all-in meeting guidelines as created by our very own Jennifer Canvasser's Next Society. For those of you who are attending for the first time, we used first names to address one another to break down the hierarchy and empower everyone to contribute. Please take a moment to review our webinar etiquette. We ask that you mute your microphone when you aren't speaking, that you turn off your camera if you're multitasking, and that any questions and comments, spoken or written in the chat, be respectful, non-discriminatory, and non-judgmental. We appreciate your help in making this space as safe as possible. As we move on to FCC Task Force leadership, I'd like to acknowledge that our organization is led in equal partnership between healthcare professionals and family partners, which is one of our key strengths. Malathi Balasundaram and Colby Day are practicing neonatologists, and Kira Sorrells, founder and executive director of the NICU Parent Network, and myself are former NICU parents. Thank you to our family partners for your contributions to our work. I love that we are diverse in our infants' gestational ages and diagnoses, and that we represent birthing and non-birthing parents, bereaved parents, and even adult preemies. You and your work inspires me every day, and I feel honored to know each of you. We'd like to welcome Erin Thatcher to our Executive Council of Family Partners. Erin is the Executive Director of PPROM Foundation. She is a NICU parent to 27-week twins and has established an impressive network of volunteer advocates to provide personalized mentorship and support to moms and families facing preterm premature rupture of membranes. Erin also serves as program manager of the Colorado Department of Healthcare Policy and Financing, and we are excited to have her invaluable insights and network join our organization. I'd also like to thank our healthcare partners for their time and support. It's rare in our local units to witness such authentic collaboration between the various disciplines of practice you represent, and we appreciate that you embody our key strength of equal partnership between all healthcare professionals and family partners. The FCC Task Force is supported by its subcommittees, co-chaired by one healthcare partner and one family partner, respectively. Daphna and Alex of our Marketing and Communications Committee manage our Twitter, LinkedIn, Facebook, and Instagram accounts. Please take a moment to follow us. They do a great job of sharing our work and events and news taking place in the NICU FCC space. Myself and Vargabi collaborate with a variety of contributors to publish a quarterly newsletter, which includes actionable takeaways for implementing FCC, a trauma-informed care corner, recommendations, and other free resources. Advocacy Committee co-chairs Carrie and Nicole keep our task force working toward big picture initiatives like zero separation and unlimited access to parents and family caregivers, and smaller but equally as important initiatives such as supporting paid family leave in the state of Pennsylvania. When I began my role as program manager in June of 2023, we had 474 members from 14 countries and 36 US states. Today, we have over 1,400 members from 48 of 50 US states and Puerto Rico, 8 of the 10 Canadian provinces, and across 56 countries. As the person who updates and measures our membership regularly, it is incredible to watch this organization grow each week, and I can't wait to see what the next webinar brings us. We've presented 15 webinars so far, with this being our 16th. Please utilize our webinar database located on our website under both the webinars and resources tab to view and share all past FCC Task Force webinars. We encourage you to share these widely with your colleagues. Take a moment to respond to our September poll. At what corrected gestational age or birth weight do neonatal therapists engage with infants in your unit? As a reminder, all previous polls and responses can be found under the resources tab of our website, with the August poll results around NICU doula support to be published soon. And I'll go ahead and share some of these links in the chat as soon as I'm finished with this update. Mark your calendars for our upcoming office hours sessions. These are an informal virtual opportunity to share your NICU struggles and barriers around beginning or strengthening FCC in your unit and brainstorm ideas for overcoming them. Our meetings are casual yet impactful, and we encourage you to register and join. Last but not least on my list of updates, how do you know you're truly delivering FCC in your NICU? The FCC Task Force's Executive Council of Family Partners and Multidisciplinary Healthcare Professionals have created a comprehensive survey to measure FCC in the NICU. To receive the survey link, scan the QR code or use the link I'll send in the chat. You'll receive survey scores and a copy of your responses immediately following completion, and will have an opportunity to meet with FCC Task Force leadership to review your unit's results. Please don't hesitate to email myself or Malathi with any questions, and we hope you'll participate in this pioneering work. At this point, I'm going to go ahead and turn it over to Colby, who's going to introduce our first amazing speaker, Susan. Thank you.
Thanks, Morgan. I'm excited to get to introduce Susan to speak for us today. Susan is the Lula O. Lubchenco Chair in Neonatal Perinatal Medicine at the University of Colorado School of Medicine. She's an associate professor of pediatrics, neonatologist, health services researcher, and perinatal quality improvement expert. She leads the Colorado Hospital Substance Exposed Newborn Quality Improvement Collaborative and the data-driven engagement of families to improve the NICU experience, also called DEFINE. She previously led the Massachusetts Hospital Safe Infant Sleep Quality Improvement Collaborative. Dr. Hwang received her medical degree from SUNY Downstate, her MPH from the Harvard School of Public Health, and PhD from the University of Colorado Graduate School. She completed her pediatric residency and chief residency at New York University and her neonatal fellowship at Boston Children's Hospital. She's an NIH-funded investigator whose research interest is in the transition of high-risk infants from hospital to home, with a particular emphasis on safe sleep infant practices to reduce sudden unexpected infant death. And I've had the pleasure to listen to her speak multiple times and to meet her, and she's a lovely individual. So we're really lucky to have her here today. Thanks, Susan.
Thank you, Colby, for the warm introduction. I'm really thrilled and honored to be here. This organization has made such a huge impact in the family engagement and neonatology space. And truly, it's an honor for me to learn from you all today. I'm going to go ahead and share my screen. Thumbs up if this looks okay. Excellent. And thumbs up if my audio is fine. Excellent. All right. In the next half hour, I'd like to share with you all some of the work happening in our state related to family engagement in the NICU, provide some broad overviews, and then highlight one of the initiatives that our Quality Improvement Collaborative has been focusing on over the last couple of years. I cannot see the chat, and so feel free to interrupt, or I'm happy to answer questions at the end. As Colby mentioned, DEFINE stands for Data-Driven Engagement of Families to Improve the NICU Experience. When we first formed our organization in 2019, right before COVID, experienced a whole slew of delays, the definition that we selected to guide our work was this one from AHRQ, which states that patient and family engagement are a set of behaviors by patients, family members, and health professionals, and a set of organizational policies and procedures that foster both the inclusion of patients and family members as active members of the healthcare team and collaborative partners with providers and provider organizations. Our group really appreciated how this definition highlighted individual, systems level, and broad policies and programs that would influence how families are engaged in our care. Now, when we first started our journey, as I'm sure many of you have experienced, the big question comes up: how do we actually measure parent engagement? Is it time spent in the NICU? Is it family presence on medical rounds? Is it parental understanding of the infant's medical condition, their demonstrated comfort or proficiency with infant care? And is it just mom and dad? What about grandparents or other caregivers? And this is something that we continue to struggle with. And so what I'll share with you today is really the good, the bad, and the ugly. You know, we're doing the work, we're very mission focused, but also recognize that we've experienced some challenges and perhaps around precision and definitions. And so I wanted to share with you a bit of the Colorado landscape as it pertains to neonatology. And there are two studies that highlight what our deficits may be. The first one was published back in 2018. Mauricio Palau is now a neonatologist at Denver Health, which is our safety net hospital. And he published this work when he was a fellow in our program. And this was a study recruited from two of our hospitals on our campus. One is our level 4 unit and the other is the delivery hospital, our level 3 unit. And he wanted to understand if there was a difference or discrepancy or disparity in parent understanding of their infant's diagnosis or reason for admission into the NICU by primary language, English versus Spanish. And so he surveyed both English and Spanish speaking parents in these two NICUs and found the following. He found that Spanish-speaking parents were far less likely to correctly identify their child's diagnosis, and families were not expected to report the actual medical terminology, but really the overall reason. For instance, hyperbilirubinemia, my baby is yellow, etc. He found that among English-speaking families, over 90% could correctly identify their child's diagnosis versus less than 80% of our Spanish-speaking families. Moreover, in the adjusted analysis, when level of education was included, he found that still Spanish-speaking families were far less likely to accurately report their child's diagnosis. Moreover, when asked among our Spanish-speaking families, he asked, well, how were you communicated with? Now, these are families that explicitly state that their primary language is Spanish. And he then asked them, well, how were you updated? And you can see that among nurses and physicians, the majority of our Spanish-speaking families reported being updated in English. And just a small fraction reported updates using an interpreter or bilingual staff. And some reported that their physicians never really updated them at all. Excuse me, I'm just trying to navigate my... Okay. The second study I wanted to highlight was this one. This was a prospective longitudinal study that recruited maternal infant dyads from 4 NICUs in our Denver area. Now, Colorado has a very large catchment area of infants and families that we serve. So in this study, we first enrolled 211 dyads and ultimately analyzed data from 177 dyads. And on the right, you'll see the catchment area of families of where they resided during the study period. And we sought to understand what were some of the factors associated with time spent in the NICU. And we demonstrated, in fact, that it was social factors, as no surprise to many of you, that were associated with maternal time in the NICU. We found that annual income greater than $100,000, travel time to the NICU if less than 60 minutes, and then not having other children in the home were strongly associated with maternal presence in the NICU. So highlighting that there are certainly opportunities, real low-hanging fruit for how do we optimize family engagement in the unit. And so as I mentioned, Define Colorado formed in 2019. We really didn't get going until much later due to COVID. But shown here is our key driver diagram. I have a lot of text here. I certainly will not cover it all, but I wanted to really highlight this, is that in our aim, we include parent report of engagement. So our first aim is improving parental report of engagement in infant health and development during NICU hospitalization by 20%. And as important, we wanted to reduce disparities in parental report of engagement by race, ethnicity, primary language, and distance from the hospital, getting at that rural-urban disparity that we see in our Rocky Mountain region. And so one key aspect of Define is that we wanted to adopt an equity-focused quality improvement framework. This is a wonderful review put together by Michelle Pena and her group. And they highlight 4 key elements that QI Collaborative should seek to ensure that they truly are equity-focused, that their data should be stratified, families and communities are partners as compensated stakeholders, really getting to root causes of the inequities and focusing on systems, not individuals. I wanted to highlight the family and community partners portion in Define. And so we work very closely with our State Perinatal Quality Collaborative, CPCQC, different from CPQCC, which is the California equivalent. And so with our PQC, we have a program that's called the FIRST program, Family Integration to Restore Trust. And really the goal of this is to center families and those with lived experience in our state efforts. It's a 2-pronged program. On the left, it's the training piece, where those with lived experience are recruited to or selected to participate in training around advocacy, QI education, and engaging with healthcare. So we recognize that those with lived experience may not have perhaps the experience or education related to some of the work areas that they'll be focusing on. Following the training, then depending on the interest and bandwidth of the individual with lived experience, they're then asked to integrate into either committee work or even at higher leadership positions within the PQC. And we are really using the FIRST program to ensure that we have family representation. This is a draft document that's hot off the press. This is yet to be implemented, but what we are putting into place is a real formal program in supporting our NICUs to engage those with lived experience in their family engagement efforts. So you can see on the left, there's clear steps that NICUs can take to include families. And then I think what's important is that there's different types of engagement, as you see on the right, that we recognize families have different interests and bandwidth. So there's different types of engagement. Moreover, it's ensuring that they're compensated for their time. And I just highlighted a bit here at the on the sheet on the right at the very bottom. And if folks have questions around what compensation looks like, happy to go into that further. I wanted to share a bit of data with you that we've been collecting. This includes data from about 8 NICUs in Colorado. And so I'll start with our enrollment numbers. And so enrollment occurs 2 weeks after admission. We have some criteria for eligibility depending on the level of unit and the number of families that that unit is serving. So families are approached and asked if they want to participate in this effort. It is not research. If they are interested, then they provide their email or their phone numbers, and they're sent, texted, or emailed several surveys during and then after hospitalization. So you can see here that we approached 739 and 483 completed the enrollment survey. And then families are sent a post-discharge survey. And this is where the drop-off happens, right? Where our response rates are far lower than what they were at the enrollment time. Now, chart abstracted data includes some medical information that are pulled by the site leads at our participating hospitals. And so I told you I'd be sharing with you sort of the good, bad, and the ugly. I think data is really hard to get sometimes, especially if we want to hear directly from families. You know, we're not interested in just EPIC or EMR data. We really want to hear from families about how included they felt in the care of their infants during NICU hospitalization. That being said, here is some of our data. On the left is the preferred language as reported by parents. You can see that 86% report English. And then we have about 14% that report others, usually Spanish. In terms of insurance, it's about a half-half split between public and private insurance. We collect some limited sociodemographic information in addition to insurance. We collect race and ethnicity. And we initially collected race and ethnicity as documented in our EMR and found that, in fact, it didn't necessarily align with what parents reported as their own race or the race of their infant. And so now we're really focused on parent-reported race. And you can see that if you were to add up these sort of non-white numbers, we end up having a non-white population in our unit of 22, in our collaborative of 22.4%. And then in terms of ethnicity, about 27% of our families report Hispanic as their ethnicity. We ask a lot of different questions on our survey, but I wanted to highlight just a couple. We ask questions around parent experience of burdens while they were in the NICU. And you can see here on the left that there is a wide range that our families are experiencing, from bills, transportation, childcare, employment, legal issues, etc. And then we see it on the right plotted over time. Now, we collect this data, and while there's some things like screening for social determinants of health, making referrals that we certainly are doing, I don't think we've addressed this at a systematic, collaborative level. And so while we collect some really good data, you know, I think we're still trying to figure out how we're going to address these things that we have greater awareness of. So those were some of the broad strokes. And now I wanted to highlight one of our efforts, and that's our Sleep Well. This is our Safe Sleep initiative, recognizing that preterm infants are at far greater risk for experiencing suffocation-related death post-discharge, and that in the NICU, we don't do a very good job of modeling safe sleep during the NICU hospitalization. So we sought to undertake this in a more systems level across the units participating in Define. And interestingly, we initially called it the Safe Sleep NICU effort, or NICU Safe Sleep. And in fact, it was our parent representatives that said that's a horrible name. We in the NICU, parents in the NICU want all of our babies to be safe. And so by calling it NICU Safe Sleep, are you saying that we don't care about the safety of our NICUs? And they, in fact, said, we can call it Sleep Well. So Sleep Well is sleeping in a healthy way to ensure the health of the baby. And it's not necessarily sleeping longer, but really, you know, how can we optimize wellness in the sleep? And so I'm going to show you some safe sleep related data from Define. So this is parent report of what they're observing in the NICU around the time of infant discharge. And so on the top, parents are reporting that they're seeing these items in the sleep area: burp cloths, blankets, toys, etc. On the bottom, this is what parents report where their infants are sleeping in the NICU. Here we have safe sleep position. And here this is stratified by parent report of what they're doing at home versus what they observed in the NICU around the time of discharge. Fortunately, the majority of our parents report back sleeping in the dark orange. But what they're observing in the NICU is that only about 50% of the time is there back sleeping, and a fair amount of side and stomach sleeping around the time of discharge. These are parent-reported post-discharge sleep behaviors. And so on the left, this is parent practice, either location of sleep as well as items in the sleep area. And you can see that there are many practices that are not considered safe sleep. On the right, this is parent report of the infant is sleeping alone. So that is not co-bedding. And so 70% report always that the infant is sleeping alone. And then we have a third reporting other practices. This is our run chart over time to look at overall safe sleep behaviors in the NICU as reported by parents. And so in the teal is the positioning, which I think is getting somewhat better over time. The blue is the location of infant sleep. And I think this is hovering around the 70% in terms of being classified as safe. And then safe items. I'll tell you, the item that always gets us is the burp cloth. So I'd love to hear from you all about what items are really hard to get out of your areas. So this is overall safe sleep compliance stratified by both parental observation in the NICU and then what they're reporting now. So while things are getting a bit better, clearly there's opportunities to do better. And so we are in the midst of developing new interventions that are really tailored to NICU families that resonate more deeply with them versus utilizing materials that exist for the general birthing population. And we know that our NICU families have very unique experiences. And I suspect that the way that we engage with them around safe sleep, the approaches that we use are usually from the general population and may not necessarily be as effective for our preterm families. And so in informing our interventions, we take some work that will be coming out. It has already come out. There's some of the research that I do. This is the first piece of a study called Safe Prep, study of attitudes and factors affecting preterm infant care practices. It's a population-based national study to understand factors that are associated with maternal decision-making around safe sleep and breastfeeding and smoke exposure. And as part of this study, we conducted a series of qualitative interviews to better understand what are some of the attitudes, norms, and perceived behavioral control that influence maternal intention and then subsequent behavior around safe infant sleep. This comes from the theory of planned behavior, a commonly used framework to understand decision-making around health practices. And so in terms of attitudes, we've learned that mothers' fear about their infant's vulnerable preterm state related to suffocation, apnea, prematurity, and reflux influence their own sleep practices after discharge. In terms of subjective norms, mothers highlighted that the education that they received in the NICU and advice from other healthcare providers, family, friends, and media impacted their choices. And then lastly, for perceived control, mothers adapted infant sleep practices to meet their own needs and address the perceived safety and comfort of infants. So clearly we felt that we need to include what mothers are highlighting in terms of what's impacting their behavior as we think about developing our own intervention practices. So with that, I do want to share this video that's still in draft form. So our Define Collaborative have invested in creating a series of safe sleep videos that are very brief, that are to be used as teaching aids for families during and after NICU hospitalization. This is the third video of 4. The first one is shown shortly after admission. The second is around the time of transition to safe sleep. This video is around the time of discharge, and the last is post-discharge. I'm going to actually stop sharing so that perhaps Morgan can show it. I fear that with my earbuds, I may not be able to make audio work effectively. I think I sent the link to Morgan, and if you're able to pull it up, I'd be much appreciative.
I got you.
Thank you.
Loaded. Of course, now it's got to reload because it is overflowing. Let's see here. I'm just gonna, oh, there we go. Ready?
For families in the NICU, it's exciting when they receive the news of their upcoming discharge. It can be a long, difficult road for families. Hearing this news can help them imagine life after the NICU. As you prepare to bring your baby home, you will need to create an environment for safe sleep. This includes having no objects in the crib, such as blankets, bumper pads, and stuffed dolls. Create a separate sleep space for your baby that is in the same room where you will sleep, with no exposure to secondhand smoke or other substances. Avoid co-bedding with any caregivers, siblings, or pets. Prior to discharge, we want to help your baby and family prepare for what safe sleep practice will be like at home. This is why, in preparation for your discharge, we have been putting your baby to sleep on their back with nothing in their sleep area since they were medically ready.
As hard as it might be, we know you can do it. We are discharging your baby because they are ready, and because we have confidence in your abilities to practice safe sleep.
Thanks, Morgan. Let me go back to my slides now. All right. So with that video, it's a mixed bag. And so I think, I'll tell you, it's probably not the way that we would have wanted it for a few reasons. And again, I'm being very frank with you. We love that it's focused on NICU babies. You see the babies with a nasal cannula in the NICU space. Very rarely do you see videos that are from NICHD or CDC that highlight the experiences of NICU families. But the thing that our team recognized after, and we didn't have the funds to go back and fix it, was if you look at the images of the parents that is in the home, they're putting their baby in a SNU, which is like a sleep space that's over $1,000, right? And so what's the messaging there? You know, and so while I think our hearts were in the right place, and it's certainly an improvement from what already exists in terms of the videos and educational materials we use in the NICU at Safe Sleep, it's not perfect, right? And so we ourselves are learning, and it's been an iterative process. So we're still in the draft phases. We're close to finalizing all 4 videos, and they'll be publicly available on the Children's Hospital YouTube site. But we're excited to now think about what does the implementation of these videos throughout the NICU hospitalization look like for our defined hospitals. There are many team members that I need to acknowledge, those from our School of Medicine, from our Perinatal Quality Collaborative, as well as our Children's Hospital, and many that are listed here, especially those that are directly engaged with provision of care and support to families in the NICU, particularly Emily Fawaz, Sarah Cahoon. And let me pause there, and hopefully I've left enough time for questions in the discussion.
Thank you so much, Susan. That was a fantastic presentation. We do have a couple of questions that came through in the chat already, and please feel free to continue typing those in if you guys have more. One of the first ones that that popped up during your talk was from Malathi, and it was about your data collection. And I know that you stated there was data that was collected from the parents just after discharge. And I think you said during discharge at time points as well, but I think we're curious about what time points you chose and maybe why of collecting that data from parents.
Yeah, when Define first started, we picked 3 time points for the parent surveys. 2 weeks into the admission, around the time of discharge, and then about a month post-discharge. Our response rates really fell off from around the time of discharge to the post-discharge period. And so we have now changed that to just 2 time points. One is during the NICU hospitalization, sort of a few weeks into admission, and then the second being about 1 to 2 months post-discharge. We found that around that discharge process, it was just a busy time, and our response rates really fell off. We're also trying kind of different strategies. We learned from one hospital that their response rates were far better when they texted parents the survey versus email. So with texting, they just got responses very quickly.
Welcome to Zoom. Enter your meeting ID followed by pound.
And so now we'll shift to, I think, trying mainly texts. In addition, we found that when primary nurses or those that knew the family really well kind of encouraged their participation and reminded them of the surveys and of Define, that also helped. So I think, relationships and also recognizing what's easy for families, I think will help with our data collection moving forward.
We also had a question from Carolyn about whether teaching varied depending on the medical complexity of the children going home. So for example, a baby with a trach, whether they had different teaching as related to this initiative.
Definitely. With the safe sleep, it really does vary. And I think it depends on where these infants are taken care of. So in our children's hospital, for instance, the infants with severe BPD who end up getting a trach, while they spend the majority of the hospitalization in the NICU, when they can be transitioned to a home ventilator, they're then sent to our pulmonary floor. And they remain there for at least a month, sometimes even several months, depending on home nursing availability. And a lot of the readiness for home and discharge teaching occurs up there. So it really depends on what medical complexity, we're having to deal with. If it's a trach, that's sort of a different kind of area where that teaching is done. And for most other things, it does happen in the NICU.
I was curious on some of your data you were showing with the sleep practices, the sleep well portion of your study. I'm assuming different centers probably have different times that they were introducing the appropriate modeling, and maybe not all had guidelines. And I was curious whether that was one of the interventions that you think has made you show progress, or if there are other interventions maybe that you think you can really hang your hat on for seeing some of those improvements in the NICU.
I think one of the most important was standardizing guidelines for eligibility for infants to start safe sleep. What we found was that for many hospitals, when the infants went PO ad lib is when they were starting safe sleep. And we know that's far too late. Oftentimes that could just be 48 to 72 hours prior to discharge. And up until that point, the infant has become accustomed to sleeping with positioning devices on their belly, and then to flip them over just 2 days before discharge. And we hear from families that the babies then go home, aren't necessarily used to that sleep position or practice, are a little bit fussy, and then families then resort to what they observed in the NICU because the infants had been stable, quote unquote, in those positions in the past. So we've developed a systematic approach to eligibility criteria, and it starts off at 32 weeks or greater than 1,500 grams. Then we ask a series of questions related to being in an open crib without positive pressure respiratory needs, and then any other medical conditions that would preclude safe sleep. I would say typically at that 1,500 gram mark, a lot of infants are still in the isolate. In my work in Massachusetts, we found that in general, at about the 34-week, the 1,800 gram mark is when most infants are eligible if they don't have other medically complex conditions. That being said, having some sort of eligibility criteria or algorithm, I think, is the first step for the nurses and other care teams to know when the infant should start engaging in safe sleep positions and practices. I think the other thing that was really helpful is if you engage families, I mean, in the practice, it makes a huge difference. So we've had instances where the families know that we're doing a safe sleep quality improvement collaborative, and they're the ones that come to the bedside and are like pulling stuff out of the crib, right? I mean, so if they know what you're trying to do, they become active players in trying to improve compliance prior to discharge.
I think that's wonderful to hear. Mia, I think you have your hand up. Is that right? Perfect. Please feel free to ask your question.
Hi. I just had a question. I know that you had mentioned about the video and like some of the learnings that you kind of had like in the post about the video. I was just wondering, I actually had like a kind of two-part, but we'll figure it out. So one of the questions that I was wondering about, what, if anything, were you guys thinking about? I know like at my previous hospital, in my previous role, like we did a lot of work around safe sleep. And one of the big things that I was really wanting us to think more about around resources was how we address social determinants of health when supporting families, because I think, to your point, like with the video, we think about like putting these things out there and like making it look this like really wonderful, beautiful way. And like everybody doesn't have access to that wonderful, beautiful optic of how safe sleep looks. So like, what have you guys done, or what are you thinking about doing to kind of address some of those barriers that like all families don't have access to, for what safe sleep looks like and how to make their kiddos as safe as possible, in their own areas without like, making them feel shame or blame or bad about not being able to do it the way that we think it needs to look. And then what education do you all provide for staff around how to communicate with families around safe sleep? Because that was another barrier that we saw a lot, because oftentimes we would have staff go in. You know how like sometimes if somebody's holding their baby and they'll just like doze off, and then like a staff member would walk in and be like, well, policy such and such says you can't. I'm like, oh, pineapples, time out, guys. Like, not policy 1213. Like, we're not gonna do that to that parent, are we? So like what have you guys done around those kind of things?
Yeah. First of all, Mia, huge fan.
Hi.
You know, I'm a huge fan of you. Yes, Mia's participating. She's helping us with our qual piece for one of our studies on IVF and inequity. So thrilled that you're here, Mia. Love you. Let me answer. So the two questions that you've asked are around social determinants of health and communication. So I think the communication piece just goes far beyond just sleep, right? And far beyond even education. It's just how we communicate with our families. Like, how are we really inclusive in ensuring that they are empowered team members? And so if truly they're a central part of our care team, like we would not go in and say, you did that wrong, or X, Y, and Z. Sort of like you would never speak to that, like speak that way to a neonatology attending, right? So it's how do we have respect for families who are at the bedside as equal partners? And offer some education and engagement in a way that you're trying to understand, where they're at. So if they are, for instance, the explicit example that you gave, sleep, falling asleep, doing skin to skin. Yes. So I think the question there is offering some education, but also ask, you know what? I'm pretty sure that this is going to happen at home. And in fact, it happened to me, or it happens to all new mothers. It's exhausting having a newborn. And so if this happens at home, like, let's think about what we could do. Or, I think the question is not if, but when you fall asleep with your baby, what's the plan going to be? Having a conversation, a dialogue, and creating a home plan with parents, I think is so important, and not it coming off sounding like punitive or punishing or judgmental. There can be a whole, I think, series of talks on communication, but I won't go there. In terms of social determinants of health, I mean, you hit the nail on the head. Yeah, we're going to tell them to do all these practices, but if they don't really have a crib, a pack and play, or even just the physical living quarters or stable housing, how does this really play out? I think for us, there are some core principles of safe sleep that we can create that don't have to look like what was showed in the video. So it is a separate sleep space, and it's a ventilated area around the sleep space. So you're not having cushions or blankets in there. So what does that look like? Honestly, it could be a drawer from a dresser. That's a separate sleep space. Now in our unit, we try real hard to provide pack and plays for families. So we will ask families and we'll screen for social determinants of health to make sure that they have the resources that they need. And for families who don't, or who may at the beginning and don't later on, then there's, I think, creative strategies that we have to think of to ensure the core components of safe sleep: separate sleep space area, well ventilated. And so I think what sort of gets at that is the baby box. A lot of controversy when the baby box came, into place. But my stance had been, well, if you're in a homeless shelter and you don't have all those resources, the baby box is way safer than co-sleeping. And so how do you adapt the principles of safe sleep to the different areas that our families reside?
I think we have time probably for one more question, and we have one from Rebecca, saying, how do you approach reflux and nursing requests to raise the head of bed for frequent emesis? And I echo this question because this is one that we talk about in our unit a lot as well.
Much of what drives our practice around head of the bed up is, I think, our gestalt, is that we think that babies who reflux and when they're totally flat really have significant apnea and bradycardic episodes. When you actually look at the data, that's not necessarily the case. And so I think first it's providing the appropriate education that in fact being flat can be protective. I think you might have all seen the NICHD images of the trachea placement relative to the esophagus and how the anatomy in and of itself offers some protection, at least being supine. Now, certainly head of the bed up, I think it falls in line with, does the baby's reflux qualify as a medical condition for which unsafe sleep practices are indicated? And I phrase it that way because we all have seen the baby who really struggles with reflux, right? The 1 or 2 babies that have to be like this. And I've had a few instances where I've discharged babies on a wedge, like the Velcro wedge, having to sleep like this on a pulse ox because they have a medical condition that precludes full back sleeping. But you have to have data to say that it is that, right? So the babies engage in safe sleep. And if you actually document that the reflux is worse and apnea, bradycardia, DSATs are worse, that should be documented and then followed over time. So they go flat, you think things get worse, but the head of the bed up doesn't get better. Let's be data informed. And if you find that if head of the bed up makes no difference, you put them back down. So I think having clear criteria and then calling certain things a medical condition that precludes safe sleep is important if you find that certain babies really can't abide by safe sleep practices.
You mentioned a pulse ox. We've seen a couple of people mention owlets in the chat. Out of curiosity, do you guys have a party line for families who ask about items like owlets going home?
So there's 2 outlets, right? There's those that you can just buy at Target or that are broadly available. And the second, that's by prescription only, right? And so the second tier, the language around their market has gotten real tricky because they've been FDA cleared, not FDA approved. So, right, so there's no product that's FDA approved to prevent SIDS, but they're FDA cleared in terms of safety, meaning the infant's skin is not going to be burned from the probe. It's safe for the baby to use it, but it's not preventing a SIDS or a SUID event. So that's the first distinction. But I have to clarify that for families, especially with this prescription tier outlet that now is being marketed. The way that I say it is that no study suggests that pulse oxes can prevent SIDS, and we don't have the data to say that the owlet grade pulse oxes are equal to, better than medical grade pulse oximeters. So in our medical profession, we don't think it's advised to use, but we say that if it offers families some source of reassurance, some peace of mind, and having a monitoring device for their baby, I say then it may be worthwhile. Some sort of peace of mind. There's some other data that families are following over time around what they perceive to be, quote unquote, the safety of their infant. So that's how I phrase it, that it offers some reassurance. It's not medical reassurance, but I emphasize that we don't have the medical data or the research data to inform its use. But if it offers peace of mind to families, then we support its use.
Thank you so much, Susan. This was a great talk. Thank you for answering all of our questions. If you guys have more questions, please feel free to chat them in, and we can go ahead and get some answers back from Susan at a later time to send out to the group as well. And now I will pass things over to Kira.
Thanks, Colby, and thank you, Susan. That really was a wonderful talk. I am very honored to be able to introduce our next speaker, Elizabeth Simonton. Elizabeth Simonton is the co-founder and CEO of ICU Baby, a nonprofit organization that supports NICU families in South Florida. Elizabeth sits on the board of directors of our organization, the NICU Parent Network, and her third child, Benedict, was a NICU baby 10 years ago. Elizabeth, thank you so much for being here.
Hi, thanks so much for the introduction. And Susan, that was really wonderful. I'm so excited about the opportunity to share our work with you and look forward to all the questions at the end. So thank you, Kara, for the introduction. And Susan, that was super informative. I want to get one of my teammates connected with you so we can leverage some of the resources you have down here in South Florida. I'm going to share my screen, and sometimes I get tied up here. So let's see if this works. Give me a second. Okay. Can you see a baby high-fiving? Yeah, okay, and you can hear me, we're awesome. So again, thanks so much for the opportunity to present. Morgan, thank you for making the beautiful collage of my Benedict. I actually took a screenshot so I can show him when he gets home from school. He always says he's the mascot of ICU Baby, so there's affirmation right there. I'm really excited to share this work that we're doing down here in South Florida. I've actually never presented publicly on it besides in grant appeals. So this is really the first time to have this opportunity, and I really want to thank you for inviting me on. The title is, let's see, let me move you all, Optimizing NICU Health Literacy and Transportation Support. And I'm going to kind of take you through how we develop these programs in a lineal fashion because it happened all together, really. Okay. So first, I'm going to give you a baseline about our organization very quickly so you have a context of what we're doing down here. We are ICU Baby, and our mission is to unite NICU families and provide emotional, financial, and information support so that babies and families can thrive together. We were founded in 2014 after my son was in the NICU, the Benedict that you saw initially, and I brought on some incredible co-founders to help me develop this organization, so it certainly has not been done alone. I want to note that all the pictures I'm featuring in this presentation are our families, and they've given us permission to share with you, and so they're particularly special to me as you see these pictures go through. Okay, our organization supports in 3 pillars. These are the pillars of support that we offer within our South Florida hospitals. So you can see we really break it up into 3 categories. Today, I'll be talking about the financial support side and the information support side. But we do have a whole line of programming, which is our emotional support. We currently cover 291 beds here in South Florida, with those hospitals on the top receiving our comprehensive programs. And those below, we're eager to get our comprehensive platform in those hospitals also, and are just diligently looking for funding in order to do that. But those hospitals below the line do have a portion of our programming, including the health literacy program, which I'll talk about at the end of the presentation. And our impact to date is that we've supported 3,798 families over the course of the last 10 years and done all this other stuff to kind of create informed decisions as we unroll more of these new programs. It's based on our experiences with these families that we're able to move the new programs forward and really take some of the information that those families provide, hold focus groups in order to best optimize our support on the floor of the NICU. And also, I always like to help point out that not only is it our tremendous team that gets this done, but over the course of the past 10 years, we've had 1,800 volunteers work with us, which is pretty amazing. Okay. So as I mentioned, we do have an emotional support line of programming, and that includes NICU PACs, a NICU Parent Mentor program, offer telesupport and bedside support. We have a meal program, which are our support groups. We have an ICU Read program. We have a foster care program, and we have bereavement support. And really, this is the backbone and the foundation of the 2 programs I'm going to talk about next, because these mentors really facilitate all the other programmatic work we're able to do. And we really pride ourselves on being able to offer very individualized support down here in South Florida, allowing parent mentors to use these 2 other programs really as tools to meet parents in their NICU journey where they are. So I'm going to start with our financial support for NICU families. Essentially, we started with our mentor program where we're going bedside to bedside in our local NICUs supporting families. So this was a veteran NICU parent coming back to support a current NICU parent. And of course, we realized, where are all the parents? We would be in the hospital and we would only connect with, say, 10 parents. Well, one thing we knew, and we were developing this kind of organically, was a barrier here in South Florida is transportation. Families could not afford to go back and forth from their home to the hospital. Number one, because our transportation system here in South Florida is not as strong as it could be, as in other cities around the country. And number two, a lot of the hospitals are located in the geographic region around the city, and a lot of our families who do have the financial need are miles out. And I'll show you some demographics, and I'll also show you some metrics as it relates to those. So we said, well, what if we provided a financial stipend every month to help these families get here? Would that increase the number of families that were able to be bedside and have access to everything being in the NICU offers them, including engaging in the care of their baby? So we looked at what's happening in our NICUs. Like I said, we saw parents were not there. We saw transportation as a primary modifiable barrier, meaning we know there's a lot of barriers. This is the one that we could impact change on the most directly. Then we looked at our metrics, and we saw that the length of stay for our mentor program was 61 days in one hospital and 42 days in another hospital, and that was the average. So these families were going back and forth pretty regularly for a long time. We looked at the distance between their homes and the hospital, and we looked at their average income. What was most alarming to us is that a disproportionate number of our Black and Brown families here in South Florida were impacted by this transportation crisis that we were having. So we thought this is another way we can impact change in that context also. Anecdotally, we talked to the NICU healthcare teams about their experience with transportation, and they helped us hand in hand develop this program. As I mentioned, public transportation is not great in South Florida. The cost of parking per day at one hospital is $12, and the cost of gas, it just all added up. When we dove in deeper, you can see these are the metrics from our metric platforms that we have. And we looked at the employment status of our families. You'll see on the first one, it says unemployed and then electing not to work at that particular hospital. And here, those options weren't changed. So we see that there's a great number of unemployed families that were in our units who needed some help. Then we looked at the people that were applying to this transportation program's yearly income. And we also realized many of them were living below the poverty line or were what we call ALICE families here in South Florida. So we decided, okay, well, what are our thresholds for determining whether or not they qualify for transportation? We made it an income-based scale. So looking at the family's income with the help of the social worker to determine who would be siphoned off to receive this benefit. And then we looked at the distance between their home and the hospital. You can see I divided these hospitals out. I haven't mentioned them by name, but just how far these families live from the hospital, 6 to 20 miles, 21 miles. What's important to recognize with Miami-Dade County, which is where we're located, is that we are an urban county. So we're not talking about highways where you can drive quickly those mileage. We're talking about an hour to an hour and a half to get 8 minutes or 8 miles down the street. The parking's so, the traffic is so challenging. So this was really illustrative to us as to why we needed to make a difference. Also, this is on our metrics platform. Again, we looked at the distance between where the nucleus or the hotspot for the NICUs are, which is where my cursor is here, and just how far families were traveling to get to those NICUs day after day to be at their baby's bedside. So we thought we were going to create our transportation assistance program, and this was in 2017. And we recognized it was going to impact racial disparities, ethnic disparities, socioeconomic disparities, and just generally disparities that we saw on the floor of our NICU. Our goals were to increase parents at the bedside, improve medical outcomes, improve mothers' ability to bring breast milk, improve access to health literacy and the ability to speak with you all, and improve access to emotional support structure, leading to parents' increased discharge readiness. So what we do is, this is the program nuts and bolts. Step one, the social worker is the one that makes the financial determination. We do not get involved at all as to whether the family has or does not have the need. Once the social worker makes that determination, she provides an application to the family using our CRM, which processes it. Once it comes through our CRM, we have a TAP coordinator review that application to make sure the basics are met. as to their qualification for receiving these benefits. Then the transportation coordinator gets on the phone with every one of the families to try to determine whether the costs are an excessive burden that prevents hospital visits, and if we give them the stipend, whether this barrier would be ameliorated. We know that a lot of people have other barriers, so we want to make sure this is the one that could be helped. Once that happens, we award transportation. Right now, we're at $160 per month per family, which is $40 per week. And for hardship funds, so for some of those families that are living very far away, or if there's a case of potential bereavement, or if there's something else going on in the family, we have the ability to go up to $320 per month per family. And what that looks like is bus passes, gas stipends, parking passes, Uber, or a hybrid award, which is really where we customize the transportation award per family. So for example, if someone needs to take a bus or an Uber to a bus stop, that's one way we can really maximize the funding given to them and make sure that they're getting to the hospital as much as possible. And then we monitor the families with the help of the healthcare teams to make sure that families are actually coming. We want to make sure if we're delivering these benefits, families are actually getting to their baby's bedside and participating in their baby's care. I'm so happy to share that that is almost always the case. I think right now we're at a 99% renewal rate. Most of the time, 100%. Once parents are given this stipend, the change is really, really, really dramatic. Since we started this program in the fall of 2017, we've given out almost 8,000 stipends, and we've assisted over 1,100 families. And when we get the testimonials from the families, we see that this is a tremendous benefit for them. What we've observed is, and this is self-reporting by parents, and this is a survey that went out over the course of the last year, is they identified what was so important about that transportation program. What is always interesting to us is talk to the nurses and doctors is always at the top. In fact, last year's survey responses, it was above Be With My Baby. So this shows you how important the transportation is for them to engage with the healthcare teams to make those decisions to learn about the care of their baby. This year, of course, it flip-flopped a little, and now it says To Be With My Baby, but that is always an interesting statistic for us. And then you can see we have lots of parent testimonials, but I just added one right here for good measure. What we've learned, we have a new hospital we've brought on, Nicholas Children's Hospital, and we are learning about unrolling that program in a new hospital where we don't have our mentor program. And we've learned a lot in this process. I love what you said, Susan, before about sharing everything. I mean, we have done some things right and some things we can improve upon, including just really relying on the social worker as the primary determinant initially for that qualification for the award. Why it works is that parents aren't waiting for rides, they're not coordinating with providers, they're not relying on other people. And what we see is the power of a car ride is so good for their emotional well-being. So we like parents to feel autonomous, to feel like they can get in their own vehicle and drive themselves over to the hospital, and that's accomplished with our gas stipends. And the most valuable component of the program is that transportation solutions are individualized to the family. The biggest barrier is funding. This is a constant replenishment fund. It doesn't require a lot of people power, but it does require a lot of what I call purse power. So I am, even this morning, writing grants to kind of replenish the fund that will allow these families to do that. Moving into our NICU health literacy program. So now we've emotionally supported the parents. We have them there because we've eliminated the barrier of transportation. We also recognize there are about a dozen plus more barriers to the parents being at the bedside. And this program, which we call the NEST, NICU Empowerment Support Tools, was kind of, again, along that lineage of program development. So we did what we did before. We looked at what's happening in Miami-Dade County. And we saw that the preterm birth rates for some of our Black families were much higher, true to form across national standards. And we saw the percentage of babies requiring NICU care was also high. And we're also here in Miami-Dade County kind of a hotbed of NICUs. We have almost over 300 NICUs just in our county alone. I'm sorry, not 300 NICUs, 300 beds in our county alone. So we have a lot of NICUs here. And then what happened with ICU Baby is the pandemic set in. And so our bedside NICU parent mentor program became a telesupport program. The mentors relationship as a result of that really deepened, and we were able to see the gaps in what these families were experiencing and what social emotional support we could provide as a mentor program. So we saw that they needed so many more resources than what we were currently offering. Then we experienced Black Lives Matter, and that really re-amplified the spotlight on the racial disparities in maternal and infant health. And we thought, many long days, nights, and hours, what can we do in our sphere of influence to make sure that we are really impacting the NICU floor? Then we looked at what society was doing, and we know we were all turning to QR codes. We were all turning to technology, short videos. And so we took all of this together to develop our NEST program. When we looked at who our parents were, we looked at these metrics, which we record daily, which shared that we were representing a disproportionate number, for the most part, of Hispanic, which is not surprising considering the composition of our county, and also Black families. We also looked at which languages were being used here in South Florida, which Susan, I thought was really interesting when you were preparing your slide that you didn't have Creole, because here Creole is such a big language. It's very prevalent, and it is something that we see quite a bit in the NICU. Then we looked at the education levels, the employment status, and the marital status of our families to try and craft this program. And we saw some pretty jarring results with regard to just the education generally. And then, of course, we looked at the postpartum depression rates, anxiety rates, PTSD rates rising during the course of the pandemic. And we thought, here's another way that we're going to be impacting change. So when I present this program for funding to my panels, I always say to my very smart panels who have degrees after their name, okay, guys, let's take a quiz. Tell me what these things mean. And when they try to do this, they can't. And so what this exposes to them very quickly is just how complicated the terminology healthcare providers are using in the NICU. And as high a level their degrees are, they also don't understand it. And now I tell them, think about those families that might not have had access to some of the education that you've had or some of the life experiences that you've had. And then I show them a sick baby. And I say, try to process all those words while you're looking at your baby like this. Well, I will tell you, we raised so much money for this program because they recognized how critical this was for folks in our backyard. So our health literacy became a combination of all these things I've shared. We developed a book, we developed online resources, and we developed short videos. And thanks to United Way, we're able to make all of these resources available in those three languages that I shared with you, English, Spanish, and Haitian Creole. And here is a lovely picture. I offered her a full screen of one of our first moms using the book that we provided her. And obviously her baby had been there for quite some time, and it was really an impactful program going right to her. Sorry, I have dogs. We're gonna hear them talk in a second. So this is the journal that we created. We wanted it to be soft and inviting for the families. We created a queuing component with several focus groups of different types of families that had been in the NICU, and we tried to cue different things for them to participate in their baby's care throughout the NICU or to ask questions. And then in the back, we wrote a guidebook, which was basically 12 topics, and you'll see them in a second, as to what those parents in our focus groups identified as, I wish I had known. All of these, by the way, are connected by QR codes. This is their online platform. So when they scan the QR code, they were able to come into this online portal, which was only for them and only for that specific hospital that was partnered with us. And they were able to access all this curated information that was not Dr. Google, but rather had been created by us with the approval and the collaboration of the healthcare teams in order to give this to the families in a more controlled way. And then we created the community resources. So as I had mentioned with the telesupport, we had seen gaps in what these families were experiencing. So we reached out to all of our partners in the city and curated resources with regard to all these additional support services that they needed in the community, and used this NEST program as a bridge to get them the services that they really needed. I just pulled out where to get resources for emotional wellness, but all of these down here have additional resources. Then we cast, scripted, wrote with the collaboration of focus groups, videos. And we wanted to keep these videos under 5 minutes to keep the attention span of the families. The idea was, what if I could beam another parent down into the NICU at the bedside of a parent that did not know what was happening, was scared, was frightened? What if I could beam someone down to say, hey, these are the ABCs of the NICU, and this is where these videos came about. What we're really proud of is we made them culturally accessible to those folks in our backyard here in Miami-Dade County, and we made them linguistically accessible. So you can see that's our English-speaking cast. This is our Spanish-speaking cast. They are all the same videos content. And this is our Spanish-speaking cast. I'm on the bottom, of course, because I was just talking about ICU baby, so excuse the funny faces. I think that was a joke on me. And here is our Haitian Creole-speaking cast, which we're so proud of, and we can't wait to get this out into more units, because this one is probably the one that is most unique to have. And then we reached out after we had created this whole platform, and we reached out to another community partner and said, this is great, but our families are using an app. Everyone's asking us for an app. And so now we've created an app. Why this program has been instrumental for us, in my opinion, is that we are able to reach a cross-section of our NICU families at the bedside. They are onboarded to ICU Babies programming immediately, and this is in their hands within the first week of their NICU admission. It provides them access to the opportunity for NICU healthcare or NICU health literacy, and it gives them an opportunity to engage more thoroughly in the care of their baby, in discussions with healthcare providers, and obviously that helps with the discharge readiness. What we say is we do not pamphlet. We want this to be a meaningful resource for them. It gives parents we give parents the orientation to the NEST program. We reinforce their usage, and we try to customize the resources so that they're not overwhelmed at all by these, but rather they see them as a tool. And when we look at the survey responses and the reaction to this, we see that they're saying they found the resources helpful or very helpful. They're more comfortable after using these resources. And you can see some of the metrics we've collected by survey. Here's a parent testimonial. And that's really what we've observed. However, it is not without challenge. This is our newest program, and we are really working right now looking at our metric dashboards. How can we do better? How can we make sure that this is in the hands of parents and that they're optimizing the usage of these resources? And what we've seen is that there needs to be a prioritization from administration and the NICU healthcare team. When ICU Baby's not there, we need them to drive home the usage of these resources, including it as part of their orientation and protocol. And why we feel like this program has been working for those parents who do get their hands on it and actively use it is that it empowers them. It's on demand. For those folks whose transportation is not their only barrier to being at their NICU baby's bedside, they're able to watch these videos from home if they don't have childcare, or from work if they don't have paid time off. It's another opportunity for them to engage in the care. And we also feel like by providing them the opportunity for health literacy this early in their child's life, they will request and demand the opportunity to engage in conversations with the providers for the duration of their child's life and beyond, which is really critical. We're setting that baseline to be included in conversations, to speak up, to make decisions on behalf of their children early on. And then finally, this is a very scalable program. I always say to my team, we can have 10 people using this, or we can have 1,000 people using this, but we need to have people using this. This does not require people power, although it was a 2-year rollout. And it just requires general maintenance. And so I'll end with this. When we talk about optimizing transportation support and NICU health literacy support, really what we see in those two programs specifically is that it gives our parents access. It's affordable to them because it's all free. It encourages them to advocate. It gives them autonomy, which is so important also, and it gives them a sense of accomplishment. And really all of those A's are critical as a parent to feel like you're engaged and you're a participant, not a visitor, in your baby's care, which are all critical to the families that we serve. And that's all I have. So I welcome any questions, and thank you so much for listening.
Thank you so much, Elizabeth. I knew that you had the NEST program, and I thought I knew what it was, but this presentation has really just shown me just how deep and comprehensive your program is. And we do have a couple of questions. One, is the NEST program available for licensing outside of the hospitals that you serve?
So we are working on that right now. I've been really reluctant to move that forward because we have seen some glitches and hiccups. So we want it to be a well-oiled machine before we can go ahead and share it. But the idea is really to share these resources with as many hospitals that need them and can see them as a valuable resource for their families. And so it's in our 2025 plan to really create that licensing agreement.
Great. That is great news because it's, I mean, so comprehensive. I can only imagine how long it took you guys to develop something, and it's just beautifully presented and obviously works really well for the families. We did have a question specific to the journals. Do they capture different gestational ages and varied medical diagnoses? I'm assuming that's all in kind of the information that they fill out themselves.
Yes, they do. And we want to make sure, we wanted to make sure it was inclusive. So when we created those focus groups, we did pull people that had very different experiences, including me, whose son was only in the NICU for 6 days. And so we try to have the parent really go through that as a way to record everything that's going on with their baby. And we wanted it to be open enough so that it could apply to every baby that's in the NICU, which is difficult, but specific enough that it would help parents really engage and ask questions and say, hey, can I kangaroo? Or, kind of step in to make those questions of the healthcare team.
Yeah. We also have a great question from Malathi, because I know you showed a lot of great data and a response from your parents. Do you have any data that your program is supporting staff and improving work satisfaction?
We have a lot of anecdotal data, but yes, particularly, I think because the transportation program's been along for such a long time, I really feel like, the healthcare teams have really relied on that right now to get some of their families who can't get there to the hospital. And what we've seen is really when we launch new programs, it takes a bit. That's why the health literacy program has only been in for 6 months. It takes a bit for the healthcare team to really catch on and to really know this resource that we have. So the transportation is something that happens very quickly. And for the nurses and healthcare teams, when they need the breast milk or when they need a decision, or if there's a family care conference, they know that that family can come because of the resources that ICU Baby has, and it really helps leverage them. With regard to the health literacy program, that's where we are now, training the teams on that program so that they're able to also leverage those resources in their discussions with families. And so that's one integration that we think is really critical, is training the teams on the program and kind of paving the way for them to lean on the program as a way to talk with their families.
So in a kind of leaning into that with the training and the transportation program, is that also something that you would train or license in some way to other hospitals that might want to develop a similar program?
Yeah, the transportation program, I think, is so really beautifully simple, to be honest. And we would love to jump on any call to help hospitals really integrate that. I know there are different laws in different states about whether hospitals can or they have to have an outside person facilitating transportation. In this case, we are, but I would love to do that. The only challenge, and I hope I mentioned this clear enough, is that that program requires such a regeneration of funds because it is a direct benefit. So while we can certainly provide the toolkit, it is identifying where those funds are going to come from so that there's a sustainable program in place.
Sure. And you said that your program, it sounds like, is primarily funded through a United Way grant. Is that correct? Or is that part of it?
Well, transportation, actually, what we see here from a 501c3 perspective is funding shifts according to some trends here in South Florida. Maybe it's like across the country. And so for a while, we were able to capture a lot of grant funding for transportation. There are different issues right now that are hot here. So a lot of the funding for the transportation program is coming from private donors. We've had 2 successes in grants lately, but it does shift. And we are self-funded. We don't receive funding from the hospitals, so we do try to kind of chase the funding where it is.
Right. Well, thank you so much. Malathi just put something. What about health insurance grants? Have you gone after those?
Taking notes. Good idea.
Yeah.
I think,
Yes.
right? We are taking notes.
Partner with your major insurers down there.
I think the more as a collective on this call that we can do to show how critical a parent is bedside, the more convincing my case is, and our case collectively is, to make sure parents are getting to the bedside. And with that, of course, comes funding.
Right. Malathi put a comment in the chat box, which, family center care only works if the families are able to be there. So thank you so much.
If they're not, they have our videos, right? And they have our I mean, that was our only solution to that. So thank you very much.
Thank you. Thank you so much. Great presentation. Appreciate you being here and sharing all of that.